Vittorio Gebbia and Professor Gializzeuli, I am so pleased to welcome you to the new horizon in the therapy of gynecologic cancer. This prestigious symposium will be held in 3 sessions. November 7th, we are going live with the first session, followed by the second and the third one, respectively, on Monday, November 14th, and Monday, November 21st, 2022. In the last 2 decades of treatment of ovarian and endometrial carcinomas have achieved tremendous progress, thanks also to the implementation of multidisciplinary boards and to the progress of knowledge of molecular biology. The seminars will discuss the state of the art in treatment of ovarian endometrial carcinomas and the new horizons of therapy. Furthermore, the impact of new knowledge on the molecular biology of this neoplasms will be discussed in depth. Ladies and gentlemen, it's my pleasure to welcome all of you who are here in this virtual room and who have patiently waited for the live stream connection. We are also here to answer as many questions as possible. During the Q&A sessions, you can interact with the speakers in 2 ways: by clicking on the hand icon, which means you raise your hand, and our moderator from the remote control room will activate your microphone. Or you can use the chat box by actually writing your question. The symposium is going to be held in English and simultaneously interpreted in Spanish. Along the bottom of your screen, you see a toolbar, and at the far right, you see a small globe under which you see the word interpretation. So, with further ado, let's get started. Dear doctors, it's truly my honor to introduce you and to welcome the directors of this amazing educational activity, Professor Giovanni Scambia, Professor Vito Chiantera, Professor Vittorio Gebbia, and Professor Gializzeuli. The stage is yours for your welcome to participants and to all faculty members, and for your opening remarks. The floor is yours. Thank you.
So, first of all, I'm happy to be part of this outstanding panel. And thank you, Giovanni, Vito, and Vittorio. It's really my pleasure. And I think it's really important that we debrief the overwhelming progress in understanding that multimodal treatment in ovarian cancer today is so complex. And I think this is even the challenge, that we put all the elements, even the new results of the ongoing and future trials with the old knowledge from the past together, and to understand what can be really the best way for the individual patient. So I'm proud to be part of this outstanding panel. And maybe Giovanni, Vito, and Gebbia, you're welcome before we go to our award winner from ESGO a few days ago with Ian McNeish. Congratulations. But let's start with this wonderful colleagues. And again, it's a global health discussion today. And thank you for taking me in this sport.
Oh, thank you. Thank you, Jalid, to you for joining us in this interesting scientific program. And I think that we will have the opportunity to discuss ovarian carcinoma, both primary and recurrent, and endometrial carcinoma. And these are 2 neoplasias in which the advancement in molecular biology and target therapies and surgery has been really very, very important during the last few years. So it's thank you again also for the beautiful, wonderful congress you organized in Berlin. And now I don't know if Vito Chiantera and Vittorio would like to add something, and then we will start.
I will be personally very short, anticipating Vittorio, and it's just a pleasure to be all here. I was just writing my residents about these 3 Mondays, and I was telling them the faculty is really the best of Europe. So it will be really a pleasure sharing experience and learning from each other. So really thanks a lot to all the speakers and the moderators. Vittorio, to you.
Thank you, Vito. It's a pleasure for me to have all of you here this afternoon in this meeting. I want to thank again Fondazione Internazionale Menarini for this opportunity. I won't use more time, and if Professor McNish is ready, maybe we can start, since we will go from microbiology to the newer treatments of ovarian cancer to this afternoon. So, Professor McNish, thank you.
Right. Good afternoon, everybody, and I would like to thank my distinguished colleagues for the kind invitation to join you today. The topic I was asked to talk about was molecular biology, state of the art and future in 20 minutes. So I shall try to do my best to address as much as I can in the next 20 minutes. And I'm going to try. These are my disclosures. So you will all know that ovarian cancer is, we now realize, not one disease, but 5 diseases. They are all driven by different mutational processes and probably all originate in different organs within the female genital tract. I'm going to talk about high-grade serous carcinoma, because obviously that is the most common type of ovarian cancer and the one that causes the greatest amount of mortality. Again, you will all know that we now appreciate that this is a disease that starts not in the ovary, but in the fallopian tube. And we see the progression from normal to P53 signature to invasive carcinoma, or intraepithelial carcinoma, and then to invasive disease. We also know that the originating mutation is in P53, hence explaining why we see P53 signatures as the first abnormality in this disease. And there have been many sequencing efforts all around the world trying to understand the complexity of this disease. So here on this wheel, we see P53 in the middle. There is a universal mutation. And around the outside, we see all the other common abnormalities that we think are drivers in high-grade serous carcinoma. Again, you will all be aware that germline and somatic mutations in BRCA1 and BRCA2 are seen in around 20%. Other abnormalities in DNA damage repair in around another 20%. And then the other large abnormalities include cyclin E amplification and loss of RB1, NF1, and P10. And it's critical to understand that these abnormalities can coincide and coexist within the same tumor, making molecular classification very challenging. It's particularly challenging because obviously this is a disease where we see not oncogenic driver mutations, but profound copy number abnormality. So on the left, we see a normal copy number profile in a diploid cell. And in the middle, you see the copy number profile of one high-grade serous carcinoma with almost chaotic abnormalities with amplifications and deep deletions throughout the genome. The movie on the right are 118 sequential high-grade serous carcinomas from a study that I ran. And again, you can see A, that they are all abnormal, and B, they all appear to be different from each other. And that's the challenge that we face when classifying this disease. The first thing that we say, despite this abnormality and this chaos, is we do have a drug that works very well in this disease. And of course, it's called platinum. In the ICON-8 study that we published recently, we looked at true platinum responsiveness in the 779 women who received neoadjuvant chemotherapy. And we know that responses are very good. The CT scan response rate by RECIST was 62%. The CA125 response rate was over 80%. And you can see that the large majority of women have improvement in their disease in the face of platinum chemotherapy. But we also know that this is a disease where, despite the excellent initial response, women recur and relapse, eventually acquiring fatal chemotherapy resistance. This is one CA125 profile of one of my patients, but you will recognize the pattern of relapse and response and relapse and eventually chemotherapy resistance. And this is the paradox. We have a very sensitive disease, yet one that relapses and responds multiple times. So very broadly, I'm going to divide the patients into three groups: the good, the bad, and the ugly, if you like. We start with the very bad, those women who have truly platinum refractory disease. In our ICON 8 series, it was only 6% of women had primary platinum refractory disease. But we also know there's probably another 10 or maybe 15% who relapse very rapidly after completion of platinum-based chemotherapy. And these women have an extremely poor prognosis. In this one study, we were able to look at the genomic features and diagnosis that are associated with primary platinum resistant and refractory relapse. Cyclin E amplification has been described before, but we also identify KRAS mutation and KRAS amplification are also statistically very much enriched in those with resistant, primary resistant and refractory disease. The Cyclin E story has been long. These are showing that Cyclin E associated with outcomes following platinum Scott-Brock study. And it's particularly true when there is overexpression or high expression of cyclin E1 protein. The challenge, of course, is how do we target this therapeutically? The partner case of a cyclin E1 is CDK2, but some of the early CDK2 inhibitors, this is PHA 793887, the early phase trials had to be stopped early due to unexpected toxicity. And certainly CDK2 is a very challenging kinase to inhibit. However, there are new multi-kinase, and this is the CDK246 inhibitor from Pfizer, that are entering phase 1 and 2 trials now, and we hope will be a potential target for these patients of poor prognosis. Moving to the other end of the prognostic spectrum, molecular biology has taught us a lot about the good prognosis patients. David Botel, a few years ago, published a genomic analysis of the exceptional survivors, identifying several groups, including the long survivor, the woman with very advanced disease who, with surgery and platinum-based chemotherapy, has a remission that lasts a decade or longer. The other one is the multiple responder, much like I showed you earlier on, but a woman who presents with advanced disease and has multiple responses to platinum-based chemotherapy. And it will come as little surprise to you that both of these groups are hugely enriched in tumors with HR defective genotypes. So the long survivor, and in particular the multiple responders, were hugely enriched in BRCA1 and BRCA2 mutations, BRCA1 methylation, with an HR deficiency rate of 80 or 90% compared to maybe 40 or 50% at diagnosis. Interestingly, a significant proportion of these patients were wild type for these HR genes, and an obvious driver was not identified. But it was also identified that the addition of RB1 loss on top of HR deficiency was associated with an even better response. So again, combining abnormalities of loss of HR with loss of RB1 appear to be associated with particularly excellent prognosis. We've known even in the PARP inhibitor days that loss of BRCA1 and BRCA2 was associated with good prognosis, especially BRCA2. But of course, the addition of PARP inhibitors has now made that even more stark. So these are the SOLO-1 progression-free survival data. And you'll be aware from ESMO this year that the overall survival data from SOLO-1, the addition of a PARP inhibitor maintenance, is strikingly advantageous to those with BRCA1 and BRCA2 mutations. The challenge comes, obviously, for the patients who do not have obvious HR deficiency due to BRCA1 and 2 loss. So PRIMA showed that there was a significant progression-free survival advantage for those HR defective BRCA wild type, and indeed for those who were apparently HR proficient. The gain was modest but statistically significant, but was reconfirmed by the Athena mono data with rucaparib. Again, a significant and meaningful progression-free survival advantage for the HR defective BRCA wild type, and a smaller but still significant advantage for those who are apparently HR defective. Interestingly, in both of those two groups, the curves certainly appear to be coming back together again later on, especially for the HR defective group. So what can molecular biology tell us about why high-grade serous carcinoma stops responding? And more importantly, what can we do to reverse this? I'm going to return to this wheel and look at specific abnormalities, starting with epigenetics. We know that around 10 to 20% of high-grade serous carcinomas will have loss of BRCA1 expression due to epigenetic mechanisms, most especially methylation of the BRCA1 promoter. Interestingly, if we go back to TCGA, important to understand that epigenetic loss does not on its own automatically confer a survival advantage. And that is, of course, because epigenetic loss can be very easily reversed, and you can get re-expression of BRCA1. Our data from Aerial 2 demonstrated that the level of methylation is critical. So if you look in the red box at the bottom, it is only those patients who had high methylation, so extensive methylation of the BRCA1 promoter, who had a good response rate to PARP inhibitors. Those who had low methylation, so some methylation, but a low level, basically behaved as if they were unmethylated. And most importantly, you have to maintain that methylation at relapse to gain benefit from PARP inhibitors. So again, these are our Aerial 2 data. Those who were archival methylated at high level at diagnosis and retained that high methylation were much more likely to have a good response to rucaparib, whereas those who were methylated but lost that methylation at relapse, none of those patients responded. The numbers are small, but the trend is very clear. And we need to understand why methylation is lost and what we might be able to do to preserve that methylation or remethylate tumors selectively at relapse. The most famous mechanism of resistance, of course, is secondary mutations or neomorphic mutations in BRCA1 and 2 that were first described only 3 years after the first PARP inhibitor papers were published. And it was Liz Swisher who was the first person to correlate those reversion mutations with platinum resistance. So in a study, small numbers, but she showed that in platinum-sensitive relapse, the chances of identifying a secondary mutation was very low, whereas maybe up to 40 or even 50% of platinum-resistant patients had a restoration of BRCA1 and 2 function through secondary mutations. In our Aerial 2 study, we demonstrated that it was possible to identify those reversions in ctDNA. And in one patient, we identified 8 separate reversion events in one patient. The likelihood of having a reversion, again, in our study, reiterated what Liz had shown, is it's much more likely in patients who are platinum resistant, but our overall reversion rate was around 8% before starting PARP inhibitor treatment. But if you had a reversion mutation, you basically had almost a zero benefit chance of responding. So the median progression-free survival was less than 2 months in patients who had the reversions, and there were no objective responses. And most importantly, by the time women had progressed on a PARP inhibitor, the reversion rate had gone up to over 25%. So PARP inhibitors are very powerful drivers of reversion events, which will explain why the post-PARP platinum response and progression-free survival in all the studies is really quite poor. And that's something we do need to address. We've also identified reversion events in other HRD genes, including RAD51C. Again, reinforcing the point that PARP inhibitors are very strong drivers of reversion, not only in BRCA1 and 2, but they can also promote secondary reinitiation of translation with truncation domain deficient BRCA1 that is partially resistant. And you can also get mutations in PARP1 itself that confer resistance. So these are all multiple mechanisms of resistance to PARP and platinum that we need to address. So of course, the question is, how can we reverse those? In the last few minutes, I'll talk about 2 mechanisms. The best known, of course, is combining PARP inhibitors with anti-angiogenesis. And there's good evidence for the combination of olaparib and cediranib. These were the preclinical data. But Joyce Liu and Ursula Maciolonis, as you will know, demonstrated in PARP inhibitor naive patients that the combination of olaparib cediranib had better progression-free and overall survival that was most striking in those who were BRCA1 and 2 wild type. But one of the most important papers was this one from the Princess Margaret Consortium, taking patients who were on a PARP inhibitor and progressing, and at that point adding in olaparib, cediranib, to see if you could resensitize those patients. A very challenging study with interesting data. So in those patients in blue who had an HR reversion mutation, once again, no response, progression-free survival 2 months, you do not respond. Similarly, those patients who upregulated ABCB1, the multi-drug resistance protein, no response. But in those with both HR mutation and those who were HR wild type, it was possible in women who were already progressing to get progression-free survival of between 5 and 8 months merely by adding cediranib. So the PARP angiogenesis combination is one that is effective in acquired PARP inhibitor resistance. The other one, of course, is adding ATR inhibitors. Lots of strong preclinical data showing that this is an effective combination, and the phase 2 CAPRI study suggested that ATR inhibition and PARP inhibitor had activity. And there you are, there were good and sustained responses. And there was a plan to run the duet study, but that has been withdrawn following the presentation of the Violette data at ESMO Breast Cancer earlier on this year by Andy Tutt. And this was a randomized phase 2 study of olaparib with an ATR inhibitor or a WEE1 inhibitor versus olaparib alone in triple-negative breast cancer. And they showed that there was really no improvement in progression-free survival in the BRCA mutated or the HR mutated cohorts. However, there was a small, albeit not particularly significant, improvement in the non-HR mutated group, with a significant improvement in overall response rate. However, that was not sufficient for the study to be taken forward. My final comment is about thinking broadly beyond DNA damage repair, because we know that PARP inhibitors, as well as being strong drivers of DNA repair, are involved in cell death, transcription regulation, inflammation, and chromatin modification. And it will be important for our future combinations, not just to focus on DNA repair, but to focus on the other activities of PARP in our combinations. And there's certainly good preclinical data that combining PARP inhibitors with epigenetic modifiers, including BRD4 and EZH2, can have strong anti-cancer effects. And these phase 1 trials are now starting, are in progress. So we come back to my patient with her relapsed disease. And the key point that we need to understand is what is happening at the end of first-line treatment when there is no obvious visible disease, but we know that there must be persisting drug-resistant clones present in the peritoneal cavity. We need to be able to identify and work out the mechanisms of those cells, and that will enable us to prevent recurrence and resistance. So on that note, I will conclude by saying molecular biology has hugely increased our understanding of ovarian cancer biology over the last decade. Defective homologous recombination is a driver of good response to platinum, good response to PARP inhibitors, and good overall prognosis. But HR proficient disease, especially that driven by cyclin E and KRAS, are a huge unmet need that we have to address. The mechanisms of acquired resistance in particular are numerous and complex, and I would argue we still need to be doing much more molecular biology to address those questions. So on that note, I will say thank you very much indeed, and thank you again to the organizers for the invitation today. Thank you.
Thank you, Jan. Thank you, Jan, for this wonderful presentation. And it's clearly evident how complex are the resistance mechanisms and how many new perspectives we can have in the future for ovarian cancer treatment. Now we move to the next one presentation, and it's my pleasure to introduce Professor Evi Sala, who recently joined our university, and we are very happy with that. So, Evis, I think that you can tell us which is the future in imaging.
Thank you very much. I'm really happy to be here. I'm showing the screen now, so let me know if you can see it. Yes?
Yeah.
Perfect. Okay. These are my disclosures. So I think we are very exciting. The exciting times have come in ovarian cancer imaging, because we definitely are moving towards next generation imaging. And what I mean with next generation is going beyond the current role of imaging in ovarian cancer, which is fairly qualitative in nature. We do a very good job on that. We really map out the disease, both in the primary setting, presentation, also at recurrence. But now we're moving into really refining the treatment response assessment, which is really difficult and an unmet need, and outcome prediction in neoadjuvant setting using what I call the combined radiogenomic approach. I'm going to really put more detail in this, and also really share our experience on automated whole volume tumor segmentation, which is really key for volumetric measurement of disease, but also for extraction of the radiomic features, as well as our preliminary experience on the multi-omic data integration for improvement in treatment response assessment. I'm also going to share with you our experience and how I see in the future the role of imaging in tracking dynamically the tumor heterogeneity to space and time. We know in ovarian cancer it presents as a multi-site disease at presentation, so we have several levels of heterogeneity, and it's important to track them not only on time but also in space. And I'm going to really focus on a novel method to accurately sample the tissue to really assess this heterogeneity using both ultrasound-guided habitat fusion biopsies in the neoadjuvant setting, but also the 3D printed tumor molds in the primary surgical setting, and how this will then fit into really applied into the novel clinical trials, but ultimately, hopefully, in clinical practice. So this is where we are now, and I think we do a pretty good job. We learn very much from each other. We learn from the surgeons. We learn from the whole tumor board. So, but this is fairly qualitative, right? We describe the disease where it is in the abdomen and pelvis, intersegmental fissure in this case, after hepatic and splenocolic ligament implants. And then, more difficult disease, lesser sac, splenocolic implants. Lesser sac, you could say it's probably more difficult to resect. And of course, then in the case of mesenteric carcinomatosis, it presents a problem for the optimal zero resection. So, however, fairly a part of a measurement in terms of how the maximum dimension, fairly qualitative in terms of description. So, the same happens with the edit quantification of RECIST measurements in the assessment of treatment response. So this is one of the patients on a clinical trial. So this is recurrent disease of presentation, and there are multiple lesions here in this patient. You can see here in the left side, left upper quadrant, there's peritoneal disease, a changed shape, but maybe if you scroll up and down, it's actually the same size or volume, and again here around the tip of the liver and further up here. However, one of the lesions here in the lesser sac, you can see it's doubled in size, so probably quadrupled in volume. So if you have to overall assess RECIST in this patient, you would actually give this patient progressive disease. Or is it really truly progressive disease? So we'll just come back to this case, and we will see how really by looking more into the texture of the disease, we can actually accurately assess if this patient is actually responding or not to treatment. Okay, so, but it's complicated, and this is that particular patient. You see, patient with ovarian cancer, they undergo multiple courses of treatment, being this chemotherapy, surgery, resurgery, immunotherapy now. So it's actually very difficult to keep track and also integrate the data, which is multi-stream, because they undergo several biopsies or several surgeries with the tissue from all those instances. So the key really is to ultimately integrate this multitude of data to better assess the treatment response. So, taking a step back, where we are now, we sit in the tumor board, and it doesn't matter where you sit. This is an American tumor board, but it could have been anywhere in the world, with surgeons, oncologists, radiologists, pathologists, all sitting in a room. And it's a little bit of a kind of organized chaos, I call it, because everybody overtalks to everybody, and then we somehow make sure that we actually reach the exact diagnosis, the exact treatment plan and management. But we could do much better, and this is where we go in not too distant future, really using the power of AI and radiomics to integrate the data and to bring those decisions to the patients. So we have a problem. We have extraordinary heterogeneity in ovarian cancer. And we know that Ian just beautifully talked about the heterogeneity in terms of the genomic heterogeneity on those patients. And there are several levels of heterogeneity. We have heterogeneity between the patients. We have heterogeneity within a patient tumor, between sites of the tumor, but also within the same lesion, so 3 levels. And we know this is a challenge because if the heterogeneity in a single lesion or even a single biopsy doesn't actually capture the whole heterogeneity in the patient. And we also know that such heterogeneity drives treatment resistance in a metastatic setting. So we do have a big challenge in front of us, but the beauty is that whenever you have a challenge, you also have opportunities. So these has led to a huge effort in the imaging community to actually develop new computational methods based on, obviously facilitated by AI and extracting the radiomic features to capture this heterogeneity both in space and time, and then integrate it with the genomics data as well as clinical data and the lab data. So just a little bit on what I mean with radiomics and texture analysis, because this is not a purely imaging audience, but it's not that difficult actually. You can apply radiomics, which is literally extracting the quantitative features of shape, randomness, how heterogeneous lesions are in terms of a grayscale or CT Hounsfield units. on a CT image, but you can do it on a photograph. And these are photographs of paintings at the Metropolitan Museum of Art. And by, just with your bare eye, you can say, well, this Mark Rothko painting on the right-hand side here is fairly homogeneous. And these Jackson Pollock paintings are very heterogeneous. And more you go to the left, this is the most heterogeneous one. Perfect. You're absolutely right. It is exactly what it is. However, by actually extracting the texture features, you put a number into the heterogeneity. So homogeneity goes down, the randomness goes up if you go to a Jackson Pollock. And this particular number becomes quantifiable, and this can be then integrated along with the other features into those integration models, which are basically done through AI. And this is not new to imaging. This is being used, texture analysis has been used a long time to classify paintings according to the various time frames and to different painters. For example, Mondrian here on the left is fairly homogeneous. You can see not much in it. It's very well defined. The color that it's using, red, is actually found only within one rectangle. And if you move to a Paul Signac here, it's fairly heterogeneous because you can see things everywhere in the canvas. So we're really using something which has been used before, but now it's possible because our AI processing is much faster and we can do that. So what we've actually built up, and this was at multiple institutions I've worked, but also here now at Gemelli, is a radiogenomics framework. When one can go from CT images to automatic segmentation. Of course, you can have multiple centers collaborating. That's the beauty of the cloud. Now cloud storage and computing, and then you can extract those radiomic features and then feed this data that I just talked about with the other clinical data, pathology data, genomics data into prediction algorithms, with the ultimate goal of producing algorithms that actually, or data integration that can actually lead to a better response assessment for this patient, of course, also to outcome, depending what you're using as the final outcome, as the final endpoint. So we started off a few years back into extraction of those features. This is 2 patients with CTs for ovarian cancer. These were CTs at presentation. So the patient here at the top has got more disease, so the volume of disease is bigger. However, disease is less heterogeneous. You'd see some more blue and less sort of, let's say, green and red here. And this patient survives for approximately a year and a half. This patient down here, less disease, is very homogeneous, and it doesn't even survive the 8 months. So we have a tool in our hand to actually describe this heterogeneity and then use it to actually predict the outcome better than just the clinical variables alone. So this data then is integrated with the data. This is the first cohort, the first study we did in Cambridge, integrating a multitude of data, ctDNA, CA125, different type of treatments, different radiomic features from CT, as well as some of the more qualitative absent or present features, for example, lymphadenopathy, ascites, pleural effusion, integrating this all together using a multitude of an ensemble of machine learning framework. And of course, being rigorous in terms of study design, having a training set, hold-down validation set, as well as the external validation set, which came from the Barthel School in London. So what are the results? If more data streams you integrated, less your error was and more accurate your prediction of treatment response was. And as you included the radiomic, this prediction became much more accurate. Adding ctDNA in this population didn't actually change very much the accuracy. And this was validated on the external validation set, apart from the ctDNA, because that cohort didn't have the ctDNA data. So we can say now we have very strong preliminary data telling us that actually heterogeneity in imaging, so macroscopic heterogeneity or phenotypic heterogeneity matters. And if we include this in our prediction models, our prediction is much more accurate than not including it all. On the other hand, or in addition to, we have a way now to map this heterogeneity, not just only quantify it, but in space and time. We can map it in space and then follow it up on time via data radiomics to see how those lesions change over time, and if there is any lesion or part of lesion that actually we think that drives treatment resistance. So we can move, well, the other thing that we can do, we can move from traditional, let's biopsy a lesion accurately, of course, and safely, to biopsying multiple lesions or a single lesion, multiple sites, because they might harbor different genetic genomic alterations. So from global radiomics to from a single target, non-targeted biopsy, we can actually move to a more precise sampling, which then we can also that can also serve understanding the radiomics features in terms of the underlying biology. So this can be done in the setting of neoadjuvant chemotherapy. So the patients have chemotherapy before actually going to surgery, before delayed primary surgery, and we use the fusion of ultrasound and CT images with radiomic features. So the patient has had the CT already. In the meantime, the biopsy is booked to actually make the diagnosis of ovarian cancer prior to starting neoadjuvant chemotherapy. And we can fuse those CT images with a real-time ultrasound, and at ultrasound, you can actually follow the needle. As the needle goes through into various habitats, you can absolutely be sure that you're actually sampling two different areas of tumor. You can do this also in the primary surgical setting, and at this time, because the lesion will come out, or multiple lesions rather, then you can actually use what we call a 3D tumor molds. And this is a small study we did on Memorial Sloan Kettering Cancer Center, but yet one of the seminal studies and papers which actually opened the field to use this technique, which is now used in various centers. So this is PET-MR, so various MRI sequence and PET, which actually tell us a bit more about the underlying physiology of the tumor, because, for example, diffusion-weighted images tells us about cell density, the perfusion tells us about the permeability and liquidness of the vessels, the tumor, and PET, obviously, about metabolism. So one can again apply AI methods in clustering here to actually derive those tumor habitats in the right ovarian mass here, which are very different to each other. That was not perceptible to free eye. And you can see here the peritoneal deposit anteriorly is similar to one of those habitats alone, just the blue one here. The 3D tumor mold is printed following an outline of this lesion, of both lesions rather, and this is the main lesion. This is the arm of the patient. This is my hand holding the mold. Each line on this mold corresponds to an image here on MRI, so you know exactly where you're cutting there, so you can sample accurately each habitat for genomic analysis. And again, just to remind you, the habitat is a unique combination here of diffusion, perfusion, metabolism, so cell density, permeability of the tumor, and metabolism, so glucose metabolism. And then from the biopsy samples, the phylogenetic tree can be constructed. Here is the trunk of the tree, obviously TP53 mutation, because it's ovarian cancer, otherwise you'll be doubting it. And then you can see that the ovary yellow and green habitats, in terms of phylogenetic tree, they actually branch together. The ovary blue and the omentum blue, the peritoneal deposit or the omentum deposit here, they branch together. So phylogenetically, they're separate, but they're similar in terms of the blue and the blue here. What is very interesting actually is that you can see that the length of the branches is longer, so it means that it's a higher number of mutations on the omentum blue compared to the ovary blue, and indeed some of the mutations that were subclonal in the ovary blue became clonal in the omentum blue, telling that disease actually got more aggressive acid, so implanted along the peritoneal cavity. Let's come back to our patient. So again, we had time point 1 and time point 2, and we did the measurements, and we, strictly resist measurement. This is progressive disease. But was it? No, it wasn't, because this large lesion here, although it became bigger, and what actually caused the progressive disease classification or resist, actually it's complete cell death. So you could, a very astute radiologist will see this line here in the middle, which means the fluid level, which is actually a sign of necrosis, but we can actually quantify it. lesion was smaller, it had a lot of soft tissue component, and had a central or eccentric fluid component. Now almost the entire lesion is fluid, very little disease remaining. So indeed, this patient had a very good partial response. So how do we actually then integrate all this information so we can bring it to the tumor board, to the MDT, to the patient, to the patient consultation? So we need to simplify, to focus and contextualize, and this is very important if we actually need to bring all those methods into the clinical practice. So what we can do, we can actually produce these dashboards that are available for discussion with the MDT, but also with the patient, so we can integrate the data. So, for example, our patient has a stage 3C ovarian cancer. We know it's a BRCA1 or 2 wild type, and we know the ctDNA measurement time. We can also incorporate the genomic report here, being that single site, but we have 2 sites. We can also include that information in our system. We can not only do this for one time point, but we're also integrated multiple time points, not only how the lesion changes phenotypically on 3D, but also the heterogeneity over time, as well as also looking at the COR25 time course, which is very important. Again, this is another patient here, which actually is, the volume is bigger of disease, but is showing a response because the cystic component is actually larger, which is what we want for treatment response. And then we can build bioflags. So we know in this patient ctDNA is going down, the cystic component is increasing. So instead of actually being our disease progression, despite the volume of disease being bigger, this is actually partial response because the disease is responding to the therapy. And we can build those bioflags as we go along. We can then compare our patient story here with other patients similar, and then we collect data from more patients, our algorithm is going to really improve and produce more accurate predictions moving forward. So I think I'm hoping that I'll give you a very brief sort of outlook of what is there in the future, maybe actually not in the too distant future. We have made this huge progress in tumor segmentation. Now in a matter of seconds, we can segment fairly accurately the whole amount of disease, and this work that was done in collaboration with the Department of Mathematics and Theoretical Physics at Cambridge, and also the Alan Turing Institute in London. Really wonderful collaborative work. We know how to define habitats now, and we also know that we can actually put some physiology into our images, because depending on what sequencer we're using on MRI or PET or carbon-13 hyperpolarization, then we can actually probe various biological features of the tumor. We can now biopsy not just safely and accurately in terms of the ovular lesion, but you can actually biopsy different phenotypic areas of the tumor. And finally, we now, of course, we can do that also on the 3D tumor models, but now also we can really integrate the data in a more meaningful way using our AI algorithms, thanks to the collaborative effort with the maths engineering community. So, where are we in the next 5 years? Well, I think we're well set to develop integrated frameworks, and we can actually reach the cross scale from microscopy, from genomics, microscopy, and then phenotype, the imaging, the microscopic imaging, not only for MRI, which is a bit more specific, but actually for good old CT, which we use every day. We now are able to improve the treatment response prediction, and also, of course, lastly, but also very importantly, engage in a much more efficient way with the clinicians, as well as with our patients. Thank you very much for your attention.
Really impressive, my compliments. I just would like to highlight something that listening to this lecture looks like you can have the feeling that this is something far from the actual information, actual strategy for ovarian cancer. But by the truth, when we discussed about that patients with the lesser sac lesion, in this case, this new ability really change not just the change the strategy. So what we will do, because We will change completely the sub-strategy for that patient. That it means giving a patient that otherwise will be not curative, a curative possibility. So really, my compliments. I saw that maybe Jalid wants to add a comment.
No, excellent. Only to confirm, and we have, I think, at the end of the day, maybe possibility to ask one or the other question. Thank you very much. I'm also very impressed.
Thank you.
Okay, so let's move forward. Again, my compliments. The next speaker will be Professor Anna Fagotti, professor in the Catholic University, responsible for the ovarian cancer unit, one of my closest friends, one of the bigger experts for ovarian cancer in our country and maybe in Europe. So it's a pleasure, Anna. Please.
Hello, thank you. Thank you, Vito, for this kind introduction, and good afternoon, everyone. It's my pleasure and my honor to be here with you today. The topic of my presentation is surgery, state of the art and new horizons. These are my disclosures. So let's start with the state of the art of surgery in advanced ovarian cancer. This is only one of the many examples that we have from the literature regarding the role of residual tumor as the major prognostic factor for our patients. And this is well known since the early 60s and has never changed over the time, although we have many new approaches and many new treatments and many new drugs. This is a meta-analysis which shows that clearly patients with complete gross resection actually have the best prognosis. There is still a role for minimal residual disease, less than 1 centimeter. And of course, the worst prognosis is for patients who have more than 1 centimeter of residual disease. And this paradigm has changed, not really recently, I would say in the early 2000s, when a new approach to these patients was introduced, which consists mainly in the introduction of upper abdominal surgical procedures, as you can see here. And this has led patients with advanced ovarian cancer to have a longer prognosis, as they never had in the past. Of course, if we consider this kind of approach with a very large and extensive surgery, we will increase the rate of complete gross resection that will never be 100% anyway. We will also increase the rate of optimal resection up to 1 centimeter, as you can see here, and we still have patients with some residuals. Also, we will include very many surgical procedures with a high surgical complexity score. As you can see here, many of the patients actually have more than one upper abdominal procedure, which includes either the diaphragm or the spleen or the lesser sac or the liver surgery, and also any bowel resection. And of course, surgical time will be much longer. This comes with some postoperative complications. This is well known in the literature, and we must consider a rate of severe postoperative complications reported in the literature of around 19%, and with a 30-day mortality of 0.8%. These are data that have been confirmed over the time, and especially after the introduction of such large and extensive procedures. And of course, a higher rate of serious complications are seen in cases with higher procedure score. But we must also consider that most of our patients, as advanced ovarian cancer cases, are frail, around 6.1%. It seems that the rate is low, but if we look at the overall number of cases, these are a consistent number of patients. And it has been demonstrated from many studies in the literature that more frail patients are less likely to undergo primary debulking surgery. They have a delay in postoperative chemotherapy, and overall greater frailty is associated with poor overall survival. So what we can do? Yes, we can do prehabilitation, and Professor Seuli is a teacher in this field, but also we can try to combine the rehabilitation time together with some kind of neoadjuvant chemotherapy, especially in those frail patients who cannot receive this kind of aggressive surgery. And if we look at the data from the literature, we have several studies, randomized trial, that have demonstrated that there is that neoadjuvant chemotherapy followed by interval debulking surgery is neither superior nor inferior to primary debulking surgery. Of course, all these studies have been criticized. They have all their own limitations, but these are the results up to now, and we are still waiting the results from the TRUST trial, which has completed the accrual, and we are waiting for survival outcomes. However, all these studies have also another secondary point, which is important, and which is the rate of perioperative complications, which seems in all the studies lower in the group of patients receiving interval debulking surgery with respect to patients receiving primary debulking surgery. Of course, you may say that those patients who undergo surgery after neoadjuvant chemotherapy are those patients who have somehow responded to chemotherapy, and therefore they have a lower tumor load, and therefore they require a lower surgical complexity score. But these are the results. And indeed, in this prospective trial, where perioperative complications were one of the primary objectives of the study, you can clearly see that patients undergoing primary debulking surgery have a higher rate of perioperative complications with respect to patients undergoing interval debulking surgery. However, you can also see that most of these cases had the grade 3 complications and not higher. And most of these cases actually had pleuric effusions, which required the thoracic insertion, which is considered a very simple perioperative event in patients receiving upper abdominal procedures. Of course, these were also patients with high tumor load and with high surgical complexity score. Another state of the art, I would say, is the possibility of including IPEC at time of interval debulking surgery. These are the results published very recently from the OVIPEC-1 trial, where you can see an improvement in terms of both recurrence-free and overall survival. These studies have, in summary, shown that the addition of IPEC to patients receiving interval debulking surgery leads to an improvement in both progression-free and overall survival. There is no difference in time of starting adjuvant treatment between the arms. That the number of patients that completed the 6 cycles of chemotherapy was similar, and the number of patients receiving treatment for recurrent disease were comparable, and toxicity was not increased by IPEC administration. Therefore, the NCCN guidelines already in 2019 considered the use of IPEC at time of interval debulking surgery for stage 3 disease. But this study has received many critics, as you can see here. I don't want to go through all these points, each of them, because there have been many description and editorials in the literature showing limitation of the study, and the reason why still today in Europe this is not considered the standard of care, and there is no consensus among us whether or not including this approach for interval debulking surgery. As you can see here, therefore, the most important point I would say in these patients is the selection of the cases toward primary debulking surgery or neoadjuvant chemotherapy. And the question is, in my opinion, who should do this and how we should do this. And if we look at the data from the literature, these are very old data, but they all show that patients who receive treatment by a specialist, I would say a gyne-onc, used to treat advanced ovarian cancer, have a longer prognosis with respect to patients receiving treatment either by surgeon or by a general gynecologist. Therefore, you can easily understand that it's not only a matter of technical skills, but it's a matter of knowledge of the disease and its evolution. And if we look at the data from the different centers, you see that if patients are treated in centers where there is a high tumor load of cases, of course, their prognosis is longer. So no matter what you decide or what is your rate of, let's say, primary debulking surgery or neoadjuvant chemotherapy, or better, not only this, because you go in a referral center where you are treated by a gynae-onc and you have a high tumor load in that center, then probably your survival will be longer. So I would like to introduce you, and you all probably know that we at the European Society of Gynecologic Oncology have defined the quality indicator for those centers who want to treat advanced ovarian cancer by surgery. You see here that we have a rate of complete surgical resection, the rate of primary debulking surgery, the number of cytoreductive surgery performed per center and per year. If you satisfy all these points, your centers can be accredited, and therefore you will receive a certification which will last for 5 years, and where you can actually can be recognized in the website and in Europe as a referral center for ovarian cancer surgery. And you see what is the situation here. In Europe, we have 50 centers accredited for the surgical treatment of ovarian cancer and 20 centers of excellence, and they are spread all over Europe. So in conclusion, who should do this decision? Who should make this decision? Every patient should undergo a complete evaluation through a multidisciplinary tumor board in an accredited referral center. And how to do it? Now, we know many different approaches, and most of the centers actually have tried to develop their own score. And the reason is that when you are trying to treat a difficult disease in difficult patients, you try to be more adjusted as possible. As in this case, the Mayo Clinic has developed this approach, which is mainly a clinical approach to triage patients toward primary debulking surgery versus neoadjuvant chemotherapy. We have developed our own scores, which includes also the evaluation of the diffusion of the disease intraperitoneally thanks to a laparoscopy. And indeed, laparoscopy is considered one of the points to describe whether optimal cytoreduction can be achieved in patients with newly diagnosed or recurrent disease. And I would like to show you how, at the end of the story, we are all speaking the same language when different scores can be applied to different populations and will obtain always the same results, especially if we are talking among centers of accredited or referral centers. If you look here, we have tried to apply the Mayo Clinic criteria to the Gemellis population. And we have analyzed more than 500 patients, as you can see here. And when we divide our population according to the Mayo algorithm, you see that we have a small part of the patients who are considered at high risk, and most of them have been actually triaged appropriately. When you look at the results, you will see that patients who have who are at high risk actually still in our population have a higher rate of 90-day mortality, and this difference is statistically significant, whereas the rate of 30-day grade 3+ complications is not statistically different, but is still higher in the group of high-risk population. And if we look at the 90-day mortality among women with severe complications, you see still here, there is a higher rate of mortality in the group of high risk. How we can explain this result? This result can mean that patients at high risk actually have lower resources to survive when they have a complication. And therefore, it is very important to identify and select patients to the best approach based on their own characteristics at time of diagnosis. And then this is another evolution of the same approach. If we consider patients at high risk according to the Mayo algorithm at time of primary debulking surgery, and we treat them with neoadjuvant chemotherapy, you see that these patients change from high risk to low risk. And indeed, what changes? Changes the tumor load. Of course, they have some kind of response. There is no statistically significant difference, but the numbers are too low. But you see that these patients change and have a lower rate of perioperative morbidity and have a lower rate of 90-day mortality. So these are patients who are at high risk. They receive adjuvant chemotherapy and some kind of rehabilitation treatment. And at the time of interval debulking surgery, they have a lower risk of developing perioperative complications and perioperative deaths. So again, patient selection is the key in this kind of surgery, in my opinion, because we have a 67% decrease of 90-day mortality from 6.1% to 2%. Triage appropriate women are resilient and are better able to recover from complications. The risk-based selection maximizes benefit and minimizes harm and should be the standard of care for ovarian cancer patients. Both neoadjuvant chemotherapy and primary debulking surgery are standard of care approaches for different populations. And the Mayo algorithm is able to identify women who can tolerate complex surgery with low risk of morbidity and mortality. The second point that I will shortly discuss with you are the new horizons for surgery in advanced ovarian cancer. So if we start with the same approach, I want to show you very briefly what are the new objectives that we will reach in the next years. Selection. Yeah, you probably know that we are trying to stage patients with advanced ovarian cancer with a more friendly approach, which is basically ultrasound, not only more friendly, but less expensive, and it may be widely diffused all over the world. This is a prospective study. The PI is Daniela Fischerova. It's a multicentric studies where different approaches are compared. Ultrasound, MRI, and CT scan. You see here the agreement in terms of overall carcinomatosis, but also in terms of diffusion of disease in different organs, as you can see here, included peritoneal and retroperitoneal disease. Results are very good, and we are continuing to enroll patients in order to reach this, the overall accrual of cases. And if you look at these, I want to show you, we are trying to repeat what we usually see by laparoscopy into ultrasound assessment. You see here, this is the mesenteric retraction. You can see very easily that the small bowel cannot move very well. It's all condensed. And the same image can be seen here by ultrasound live or with specific figures, which remember as this mesenteric retraction. And the second step is trying to reproduce all the variables that we have affected by laparoscopy thanks to ultrasound. As you see here that, for example, diaphragmatic carcinomatosis can be recognized here, or the presence of some liver nodules can be recognized here, and so on. Of course, this is not easy. This is mainly a operator-dependent procedure, like surgery, the same. And of course, it may have some biases and some difficulties, mainly related to the presence or absence of ascites, for example. But we have been able to reproduce all these variables through ultrasound. Another, we hope very soon, result is the one that should come from the TRUST trial. Professor Seuli is one of the investigators, so he can update us on the current status. However, this is a prospective randomized trial comparing again neoadjuvant chemotherapy with primary debulking surgery in patients with supposed advanced ovarian cancer from stage 3B to stage 4. These patients are randomized before any kind of exploration, so basically based on CA-125 serum level and CT scan. And here you see the trial. We know that the enrollment has been completed, and we are waiting for the results. And also, at time of PDS, we have now another trial on IPEC. You see here patients with who undergo primary debulking surgery, stage 3 cases with complete or near complete cytoreductive surgery are randomized to receive IPEC versus non-IPEC, and then followed by adjuvant treatment and maintenance according to the policy of the center. And we are enrolling cases. We have enrolled around 150 cases of 538. These are other information. But also, I think that the results that we have obtained with the medical treatment are very challenging for the surgeons, and probably we will discuss later with Professor Pignata. Anyway, I think that these results from the SOLO-1 trial have clearly shown again that the best survival is obtained by patients who receive complete gross resection at primary surgery. But also, these other two results are important. You see here that patients receiving PARP inhibitors and who have residual actually seems to have a better prognosis with respect to patients who have no residual but do not receive PARP inhibitors. So I think that we still need to understand very well, and it's not clear how to manage surgery and PARP inhibitors. Having said that, primary debulking surgery with complete gross resection has always the best prognosis. This is another way to demonstrate the same result, but I also like to show you these other results from the PRIMA trial, where you can see very easily that, again, that the effect of PARP inhibitors at time of in patients receiving interval debulking surgery are very good and nearly as good or even more better than patients receiving primary debulking surgery with residual disease. So again, very challenging time for we as surgeons. Regarding interval debulking surgery, we have another trial which has recently started on IPEC at time of interval debulking surgery in patients receiving adjuvant chemotherapy that is very similar actually to the one that we have seen with the Van Driel trial, just to demonstrate whether this trial is safe and effective for the same subset of patients. At time of interval debulking surgery, we have also another prospective randomized multicentric trial, which is going to randomize patients receiving 3 to 4 cycles of neoadjuvant chemotherapy and complete or partial response, but with CA-125 serum levels negative. You see here that these patients are tested for response and then randomized between laparotomy and a minimal invasive approach, and then they continue with standard chemotherapy and maintenance. And the main, this is a non-inferiority trial where the main objective of the trial is to demonstrate no difference in terms of disease-free survival between the two groups. I think it's interesting, the design, because here we have the whole group of around 600 patients divided in 2 parts. And the first part is the leading pilot trial, enrolling the first 100 patients. And the objective of the pilot trial is actually to determine the feasibility when the accrual rate is good enough. The crossover is less than 25%, and the difference of complete resection towards 0 is less than 20%. You see here the first data on accrual of 100 patients. 70 were enrolled in September. Now we have 80. So I think we are going to complete the first part of the trial, and we will have the results very soon because we don't need any kind of follow-up for the feasibility part. And this is the last point I would like to discuss with you. So with all this in mind, the past and the future, what we are missing today. And I think what we are missing today is a molecular-driven surgery. All these studies have been performed without any information regarding the molecular aspect of the tumor of our patients. And although there are some kind of limitation related to heterogeneity of ovarian cancer, we still make make some hypotheses. If we think about patients with different histological subtype, we can also underline their different molecular aspect. Each subtype, histological subtype in ovarian cancer has a different molecular and corresponding molecular aspect. And therefore, as you can see here, based on the studies that we have until now, we can also make some hypotheses when primary debulking surgery is suggested and when or recommended, and when we can imagine that some kind of neoadjuvant chemotherapy could be offered. And basically what we know today is that neoadjuvant chemotherapy can be offered in those patients who have more chemosensitive tumors. Another kind of molecular surgery is, of course, any kind of risk-reducing surgery, both for BRCA status or Leach syndrome, both for ovarian cancer or uterine cancer. And these are some of the trials that are now ongoing. But we also know, and this is something that Jan McNish has already shown you, is that some tumors, actually, some still high-grade serous ovarian cancer are more chemosensitive than others. This is an experience from the Russian group, but it is exactly what Jan McNish has already shown you. Patients with a BRCA mutation are more sensitive and they have more frequently complete or partial response to neoadjuvant chemotherapy. And these are some data that we already demonstrated in the past, where patients with a BRCA mutation have actually no statistically significant difference in terms of progression-free survival, whether they received primary debulking surgery or neoadjuvant chemotherapy. And these results have been also demonstrated by the same group previously. So I don't have any new data in this regard, but I think that this is the time to think about this and really to design a prospective study based on a molecular-driven surgery. And this is my conclusion. Thank you very much for your attention.
Thank you to Professor Fagotti for her wonderful, exhaustive presentation. And now it's my pleasure to introduce my friend, Professor Sandro Pignata. I know him since 30 years, I think, Sandro, no? Maybe more or less.
Yes.
It's up to you, go.
Ciao Vittorio, and hello to everyone. Thank you for inviting me to this wonderful symposium. I really enjoyed the previous talks. So my disclosure, my topic is how to introduce medical therapy in the algorithm of ovarian cancer treatment. And so just to summarize what has been already said clearly by Anna, the attempt to complete cytoreduction is still the standard with no macroscopic visible disease as target. And this is very important because, as stated before, what can be achieved with an optimal cytoreduction is difficult to be achieved with any drug. So the outcome of the patients that receive optimal cytoreduction is so good that it's really a pity if we do not have an attempt to have this at the beginning. It is debated the role of interval debulking surgery after neoadjuvant therapy, as stated before, but I think that in this moment, neoadjuvant chemotherapy should be given just to patients with poor performance status or contraindication to surgery, or with an extensive tumor dissemination that make unlikely an R0 resection. Regarding chemo, the standard is 3 weekly paclitaxel carboplatin. We have done a number of studies trying to improve, but it's 30 years that this is the backbone for the medical therapy in ovarian cancer for any histological type. As stated by Anna, regarding the question neoadjuvant or adjuvant chemo after primary surgery. Only the TRUST trial will give this response, but I think we will need to wait a couple of years to have the final results. So what is important is to go better after the 6th cycle of chemotherapy, because we know that these tumors are highly aggressive and the recurrences are very frequent. So we need to do everything to delay the progression of the disease and to avoid the recurrence or delay the recurrence as much as possible. And to do this, the only strategy that we now consider is the strategy of maintenance treatment. So what is clear now that almost all the patients should receive a maintenance therapy after the chemotherapy. But which kind of maintenance therapy? It's good that now we have several options. We have the option of single agent PARP inhibitors, the options of bevacizumab alone, and also the combination of PARP inhibitors and bevacizumab. How we decide how to proceed? And mostly, as previously said, we decide our therapy according to the molecular characteristics of the cancer. And we know that for high-grade ovarian cancer, around 50% of the patients can be considered HR deficient. 30% of the cases is dependent from a mutation of BRCA at germline or somatic level, but also, as Jan underlined, also epigenetic mutations may determine this deficiency. The instability, it's the main characteristic of this cancer and is typical of the patients with homologous recombination deficiency. So today we decide the therapy after having evaluated the molecular status. So if we have a patient that has a BRCA1 or BRCA2 mutation, both at germline or somatic level, we have two options in this moment. The first is a single agent PARP inhibitor. We have data and we have commercial olaparib and niraparib in this moment, but also the combination of olaparib and bevacizumab is possible, not in Italy because it has not been approved by our regulatory agency. So these are these two options for BRCA mutated patients. And these evidences come from some studies, in particular from the SOLO-1 study that randomized patients in response to chemotherapy with complete or partial response to receive 2 years of olaparib versus placebo. So in this study, we have over time seen first the 5 years after the primary analysis that was positive, the 5 years PFS data showing that around 50% of the patients in the olaparib arm remain free of progression. But very recently at ESMO, we have seen the 7 years data regarding overall survival. And as you can see, 67% of the patients are alive at 7 years. So you need to remember that previously just 10% of the patients were alive at 10 years. So the data with the PARP inhibition in ovarian cancer have dramatically changed the natural history of disease. And these patients, in many cases, are patients that have not progressed and have not received a further therapy. And it's important to note that the effect of the PARP inhibition remain longer after the interruption of the drug at 2 years, thus suggesting that possible other mechanisms further to inhibition of PARP may determine this long-term control of the disease. And as Anna said, one could think that if we have a so effective drug, drug, we could skip the primary surgery. And this is not the case, because as shown, the best results, even for olaparib in BRCA mutated, are obtained in patients that have received upfront surgery, and in particular, that have no gross residual disease after primary surgery. And this is, if we think about this, it's reasonable, because with primary surgery, we eliminate the most of the cells that are primary resistant to platinum and olaparib. So in BRCA mutated, that is a very sensitive disease, the primary surgery with optimal cytoreduction has a very important role. But in the same setting of BRCA mutated, we have also niraparib, and the data come from the PRIMA trial. That is quite different from the SOLO one. First, because it included also non-mutated patients, but second, because the patients that were enrolled had residual disease at primary surgery. So a more advanced population and a more high-risk population of ovarian cancer. Here, there was a pre-planned analysis of the molecular subtype of the disease. And if we focus on BRCA mutated, you see the a similar hazard ratio compared to olaparib for niraparib in the setting of BRCA mutated patients. So the drug is very effective with long-term control of the disease in the BRCA mutated population. Regarding the question of the residual disease, as I said before, PRIMA was limited to patients with the residual disease. But more recently, another trial, very similar in the Chinese population, the PRIME trial, have included both patients with the residual disease and no residual disease. And then, as you can see, the results are even stronger in the PRIME trial, particularly the difference in the proficient population that was quite small in PRIMA was higher in PRIME. So it is likely that if we extend the use of niraparib to the patients with optimal cytoreduction, we can obtain even better results. And then last, the PAOLA-1 trial that also included mutated and non-mutated, that randomized olaparib bev versus bev. And here also there was a subgroup analysis. And as you can see in the BRCA mutated population, there was a very strong effect of this combination compared to bev. The only limitation of this study is that we do not have in this trial an arm with only olaparib, so we cannot judge definitively on the synergism among the two drugs. If you go to the second population, the homologous recombination deficient, in this moment we have two options: niraparib single agent or the combination of olaparib and bevacizumab. So if we go back to PRIMA, in the HRD population, you see that there is a very strong effect on niraparib. What we learn from this study is that this population of HR deficient BRCA wild type is very similar to the BRCA mutated in terms of responsiveness to chemotherapy and PARP. And the same was in the PAOLA-1, where we observed a significant benefit for olaparib bev compared to bev, as shown in this picture. More recently, at ESMO, the data of PAOLA-1 have been presented, and as you can see, while overall survival was not different in the two arms in the intention to treat population, when we focus on the homologous recombination deficiency, here we were able to find a statistically significant improvement in overall survival. It's not easy to reach overall survival benefit in ovarian cancer because of the long post-progression history of the disease. In particular, in this study, around 50% of the patients randomized in the placebo-bev arm have received PARP inhibition in later lines. So nonetheless, in this trial, we were able to observe an overall survival advantage in the HRD population. And even in this case, as in Solo 1, the results was better or probably better in patients with optimal site reduction and no residual disease after primary surgery compared to the patient with aggregates. Just underlining another time that the role of primary cytoreduction is still there, and we need to have a good surgery up front. The third population is the proficient. Here we have only two possibilities, the single agent niraparib and bevacizumab. And the single agent niraparib come from the PRIMA trial, as I have shown before. You see, this data is statistically significant. However, the difference between these two groups is smaller. And even in this case, we miss another arm, that is the arm with bevacizumab alone. So we cannot compare directly a maintenance with niraparib with a maintenance with bevacizumab. So I would say that in the proficient population, we cannot conclude definitively that the PARP inhibition is the standard of care in this moment. In the Paula one, also was explored the proficient population, and here was the first time that the test for homologous recombination deficiency was able to identify a population that cannot benefit. So here, the proficient patients do not benefit from the addition of olaparib to bevacizumab, and so should not be used. So the state of the art is that we have different possibilities, different opportunities according to the molecular characteristics. And at the end, we will have another drug in this setting, that is rucaparib, because as shown before by Aina at ASCO, rucaparib as maintenance has shown statistically significant benefit in both HRD patients and intention to treat population. So we will have another drug soon available. And let me remind our MITO 25 trial coordinated in Rome at the Gemelli that is testing rucaparib versus rucaparib bev and bev alone. So probably this trial will be able to answer to some questions still open after the Paola 1 trial. So one point is clear. We need to test homologous recombination deficiency in our practice. And usually we do it with the Myriad My Choice that have 3 different tests to evaluate a genomic score. These measure the scars in the DNA that are present when there is an homologous recombination deficiency due to the genomic instability. So first of all, we need it in clinical practice. My Myriad is now the standard, but it's expensive and is not reimbursed in Italy. And so probably other kind of tests need to be developed, other commercial or as in our attempt, academic HRD testing are expected. So this is our experience with the HRD testing. We have compared with Myriad the tests for genomic score done in 2 different labs with 2 different methods. One in Humanitas in Milan, very similar to the Myriad test, and the second in Naples and Sicily, using a different method with whole genomic sequencing. Well, in these 2 genomic tests compare and agree with the results of Myriad in more than 90%. So the concordance is very high. We also tested another test, the RAD51 foci, that is a functional test to see if the pathway that appears impaired genomically is really functionally active or not. The test is not easy. It was possible to have this test only in 65% of the patients. Well, what is clear that the agreement rate is very low. So there are patients that have a genomic alteration that have no alteration in the functional activation of RAD51. So I think this combination of functional and genomic testing is one of the things we should do in the future. Very recently at ESGO, it has been presented one of the academic testing done in Geneva on the Paula-1 consortium. Is a test that has been evaluated on the samples of the Paula-1. This is very interesting in my view, because you see that there is a good concordance between this academic test and Myriad. Even in this case, the majority of the tests have concordance with Myriad. There is a lower failure rate. This was the case also in our academic Mito Mango test. But what is interesting is that even in this case, they were able to find some discordant samples. And it's probably that looking deeply in these discordant samples, we can find something more. As you can see, there were 6 samples that were Geneva negative and Myriad positive, and 28 samples that were Geneva positive and Myriad negative. And as you can see by the curves, there is the possibility that some other patients further to those identified by Myriad could probably benefit from PARP inhibition. So I think this is something that will be our future for our research. So for sure, this test can be improved, and the biology should be more deeply explored to understand who respond and who do not respond to PARP inhibition. So to conclude, the primary cycle reduction for me, that I am a medical oncologist, is still the standard of care. All patients need to be tested as soon as possible with BRCA and HRT status after surgery, and patients with a partial or complete response need to receive a maintenance treatment. I think that we are at the beginning of the history of the molecular characterization of ovarian cancer. I think the HR tests that are currently available are not optimal. And so in our consortium, we will continue to research for better tests that can select the patients that benefit and that are resistant. Thank you.
Thank you, Sandro, for your presentation. Now there is a open question section if we want. Maybe Professor Seuri wants to drive the conversation or not.
Okay, so first of all, again, thank you for these excellent overviews. But maybe let's start with Ein Magnish. So can you give for the audience a statement about HRD tests, and how is your impression where we are from the academic point of view? Can we use them? Are there differences? Are there any quality indicator? We just had some presentation at ESGO a few days before. So what is your general statement for the clinician, how they deal with this, and where maybe you see the limits?
Okay, that's a good question, and I do not have answers to all of those questions. So most of the assays that are being developed are looking for types of genomic scars, looking for damage in the genome, and many of them are looking for similar parameters. So the gold standard is clearly, one, can we identify patients who do benefit from PARP inhibitor therapy? Can we identify patients who do not benefit from PARP inhibitor therapy? And can we get a test that can be done rapidly, preferably cheaply for not too many euros, and for which there is a very low failure rate? So if you look at all the studies with the Myriad, there were between 10 and 20% of results as samples, it was not possible to get an answer. That's incredibly important, especially for those women who are undergoing neoadjuvant chemotherapy and you have an either image-guided or a laparoscopic biopsy. So at the moment, the Myriad assay is the gold standard because it has been validated in clinical trials. However, I'm impressed with the data from the Geneva group because they were getting very similar answers that were strongly correlated with the Myriad, but their failure rate was much lower, and the test can be implemented in a routine genomics laboratory. The Leuven test has also been presented, and that similarly is highly correlated with the Myriad assay and can be implemented at lower cost with a low failure rate. So I think all of these assays that are being developed, if we can demonstrate strong correlation with the published data with a lower failure rate, I think all of them are equally valid. The challenge will be to develop assays that are non-genomic based, because we all know that at relapse, the genomic assays do not change, whereas the tumor can revert and lose its HR status. So there will be a challenge for us to develop assays that work in relapsed disease. And I know groups are looking at RAD51 assays, but as Sandro showed, those are much more technically challenging. So that's a very long answer to a simple question. And I think we've got multiple academic assays that will be implemented very shortly in the first line state that I think will be equally valid as Myriad and that we'll be able to use for our future academic studies within Europe. I hope that answers your question, Jalit.
Yes, no, perfect. Only to give one comment. I just had today a meeting with our pathologist because we also have developed two HRD tests, one from the NOGRO and one from the AGO consortium within the Paola consortium. Yep. And I think what is really important that we really understand what is really meant by HRD tests. So not always it's the same multidimensional genomic instability description. And second is, let's work together as Europeans and globally to develop much better, because it's very helpful to use the stratification. But if we look how many patients are progressed within the first year, they are not really the cohort who really benefit from a maintenance approach. I think we have to better understand this is only possible if we share our experience, we share our data in one global registry and to become much better. So this is, I think, the positive signal we have so far.
I think the Paola consortium deserve many congratulations for sharing their data and sharing their samples. Yes. And I hope that other trials will do the same. It is still perfectly possible, Jalid, to be HR defective and still progress rapidly. We know mechanisms can change and the drivers of reversion and loss of HR function are really complicated. But I agree, working globally, sharing samples, sharing data has to be the only way to go. I'm aware that Anna Fagotti has got her hand up, so I'll stop talking.
No, just a question for you, Jan, if I can. The question is the following. Do you think that the failure rate is related to the amount of the sample? Because actually I've seen some publications, not for HRD, but for other testing that do not relate exactly with the amount of samples that we give as surgeons. What do you think?
So it's a very good question. So for genomic assays, the critical thing is the quantity, not of the sample itself, but how many tumor cells are in there. So you could have a very large sample, but if it's very fibrotic or has got lots of stromal tissue, you may still have a low tumor cellularity. So you want the sample with the highest degree of tumor cellularity. And ideally, if it's going to be formalin fixed, it should be fixed for around 2 hours. If you fix for too short a time, you get necrosis. If you fix for longer than that, you get formalin fixation artifact. So it's got to be a high tumor cellularity sample that is fixed for about maybe 2 to 4 hours maximum. That's the ideal amount of time. But later on, we may be moving towards frozen samples where you get much higher quality DNA that's much less fragmented. So you are correct. There are many factors that determine the outcome of the assay, but high cellularity fixation for a short amount of time is ideal.
Thank you.
Only one comment, Anna. So we looked on the NOGO HRD test, and half of the samples where with the Myriad test was not possible to make any calculation was done in the other HRD test. I think I'm not a lab guy, but it seems to be really different technologies, and they have a different sensitivity. So that's what I learned. And even from the Geneva colleague, there were even amount of patients because there were the same samples where the test gives some results. Yes.
Yeah.
Yanni, just one question. Do you think that proteomics could have something in ovarian cancer? In a short period, I mean, in a short period of time.
So it's a very good question. And the short answer is I'm going to yes and no. DNA at least has the advantage of being pretty stable. So you can take a sample, fix it, and the DNA will, in theory, be stable for a long time. Proteomics will require really high quality, preferably fresh frozen material, so that you get maximum. You can do proteomics on formalin fixed tissue. It's less informative, but clearly all cellular functions are driven by proteins. So I think if we can start getting proteomic signatures, that will give us more information, especially at relapse when tumors are evolving. But proteomics is incredibly complicated. So I don't think it will be this year or next year, but maybe 5 years, we will be developing proteomic signatures for specific subsets of patients, but not yet. I think we're not ready for that yet.
Thank you.
We have still few minutes. I don't think there are questions from the audience. Anna, I would like to have a comment from you, because you discussed about selection of patients. And this is, from my personal point of view, one of the main points. And many of you have worked on different aspects on that point, laparoscopy, fragility of the patients, Professor Sala about the radionomics, how we combine all those. Because at the moment, personally, I'm a little bit confused, because we have the surgical aspect, and so the macroscopic aspect of the tumor, we have the molecular aspect of the tumor, we have the radiological aspect of the tumor, we have the biological aspect of the patients. How is your vision? How we are going to combine all those?
So, Vito, this is a very difficult question. And
artificial intelligence.
Yes, this is the answer. Yeah, I mean, in the future, probably this would be the way to go. In the meantime, actually, what we are trying to do is to have a step-by-step algorithm for decision. So basically, we are trying to get information, all that we can, first by clinics, and combine it with radiology, and then only those patients who pass through the first step and seem to be resectable, let's say. It means from their fragility status, based on radiology, based on other factors, then these patients will be assessed for a laparoscopy, and then if they pass through the second step, then they will be resected finally. So this is how we do now. We would like to implement molecular factors for surgery. And let's see, we are trying to do this. We have a trial in this sense, but the most difficult point, and this is something that I would like to ask to Yain again, is that it takes time to have this kind of profiling for patients. So we don't have this time in these patients. Usually we try to have a treatment, whatever it is, within 2 weeks from the first contact. And this is not enough to get this information. Even though we provide samples through any kind of biopsy, it takes time. So I don't know if in the future we can have the results in a shorter time.
My pathologist always says, Ian, you can either have a quick answer or you can have the right answer. Which one do you want? I think we have one advantage in high-grade serous disease in as much as platinum chemotherapy is still effective. So I would have no worries about giving one cycle of platinum chemotherapy whilst waiting, because I think these are complicated assays. If you look at the algorithms behind the genomic assays, they're actually really complicated, and the informatics required is not trivial. So I completely understand your point. So I would have, I maybe see what you think, but you get a sample, the patient starts on chemotherapy, and then usually by 3 weeks, you can definitely have an answer, and that will help you. I think there will be no harm in giving one cycle of platinum chemotherapy, but I'm interested to hear what you think.
Yes, no harm and probably no differences.
Yeah. Almost nobody would progress after one cycle of chemotherapy, even the most refractory patients. So that's my only thought, if time is really urgent.
So I love the idea of window of opportunity. Nevertheless, all trials at the moment failed to predict by molecular profiling which patient are really the best candidate for surgery. We had two nice presentations the last 2 years about this prospectively. It's maybe because it's multidimensional, but at the moment, I think we have even to accept there's no molecular profiling who is really able to predict the best surgical outcome. It's maybe based on the mixed patient population. They are frail patients, they're patients from the tumor pattern not suitable for surgery. And maybe we have to clarify these cohorts even in our surgical trials. But nevertheless, windows of opportunity is nice. But at the moment, I think we agree we are not able to predict by profiling.
Yeah.
Well, it's 6 o'clock. There are no more questions for the audience. I see. Maybe Professor Silvi wants, Giovanni want to make some more take-home message and then close the section.
No, I think that it was a very interesting session, and I think that ovarian cancer still deserves great attention from a research point of view, but we are doing a lot of progresses, and this is something very, very important for us and for all our patients. So thank you to all for the participation, and we will see in the next meeting next week. Okay.
Next week.
Okay.
Thank you very much indeed.
Bye. Bye.
Bye. Come see us.
Bye. Thanks you all.
Bye.
Thank you. Bye-bye.
So let me conclude by thanking all of the faculty members for your time and valuable insights. Thank you for bringing your expertise and experience here today and engaging in such fruitful, constructive, and open exchanges throughout the first session of this amazing educational activity. Oh, by the way, I just got a message from our control room. We have just had 960 viewers from all over the world participating in our webinars through our virtual platform and all our social media channels. Wow! Being this only our first session, this is a big achievement. We are extremely proud to announce that and truly grateful to each and everyone. Many thanks to all of you who have followed us during these hours rich in content of high scientific value. And of course, we pay a tribute of high gratitude to Fondazione Internazionale Menarini for organizing this amazing symposium. The session has been recorded and will be available on demand in the Scientific Library. We look forward to welcoming you again on Monday, November 14th for the second session focused on recurrent ovarian carcinoma. Thank you for your attention and arrivederci.